I'm Dannielle Chammas. I'm an outpatient palliative care doc at UCSF in the symptom management clinic.
Hi, everyone. I'm Keri Brenner. I'm a clinical associate professor at Stanford Medical School, and I do all inpatient palliative care.
Hi, all. My name is Dan Shalev. I'm a predominantly inpatient palliative care attending at Cornell and spend most of my time doing research on palliative care and psychiatry.
Hi, I'm Sam Weisblatt. I'm the lead hospice team physician, and I do predominantly entirely community hospice in New York City at an agency called VNS Health.
Awesome. So the four of us, as you probably figured out from the flyer for the event, are also psychiatrists. We all trained in psychiatry before making our way to palliative care fellowships. And at the end of the webinar, when we do Q&A, we're going to have Carly Zapata join us. She's the fellowship director at UCSF. So if there's any sort of technical logistical questions, she can help with those too. And just to let you guys know up front, our plan today was just for each of us to spend a few minutes telling you a bit about our journey and how we landed in these training paths and these careers, maybe give you a little sense of what some of the pros and the cons have been for us. And then we really want to leave a lot of time at the end for Q&A because it's so deeply important to us that this is actually helpful, actually meaningful to you. So I will kick us off. I did my medical school, my residency in psychiatry, and my palliative medicine fellowship all at UCSF. And like I said, I practice actually part-time right now in palliative medicine at UCSF. And although I personally really love inpatient palliative medicine, and I miss a lot of pieces of it, outpatient palliative medicine was actually really well suited schedule-wise to this phase of my life where I have three very little kids with me quite a bit. So I have an outpatient clinic and the symptom management clinic, and I moonlight every once in a while in psychiatry on the weekends, both for a little extra cash and to keep those skills of more intensive psychiatry active. And my path here, it's interesting. I actually fell in love with palliative care as a third-year medical student. And I knew it. I decided like, I'm going to end up in palliative care. And I didn't even know what kind of residency I was going to do. And I really agonized between this decision between internal medicine and psychiatry, because so many people were saying, well, if you know you're going to go to palliative care, it just makes sense to do internal medicine. But I found myself so drawn to learning the skills of psychiatry and being able to bring those skills to palliative medicine. And I found just inside of myself as I was debating that anytime somebody would give me the feedback, just do what calls you most and have faith that you can make it work out, I felt really relieved. And actually, I'll share a funny story is that I emailed Steve Pantelat, the head of palliative care at UCSF, as a third-year medical student with this debate that I was having. And he wrote back this kind reply of, oh, it's a multidisciplinary field. You can get here from any path, do what your heart tells you. And then fast forward 4 years later, he didn't remember me. He didn't know me when I emailed him, and I was interviewing for fellowship. And his first question was, do you think you can handle this career having come from psychiatry? And I got to remind him of his own email and his own words, and that might have helped me get into the program. But anyhow, so I'm not a baseline a risk-averse person. It was an internal challenge for me to deviate from what looked like the well-defined road. Other challenges for me, I guess, psychiatry residency, despite giving me great skills, didn't have any palliative care experiences. And I actually had to work very hard to find a way to create an elective, to convince the people in my program that it made sense. And it was one of our subspecialties. And, I should be able to get exposed to it early. When I came to applying, there were some programs who wouldn't even interview a psychiatrist, which was frustrating for me that from the outside people might question my competence to do the work. And then there was also an internal piece of me that I think not always, I'm past it now, but for a while kind of wanted to prove myself because of that. And I would say the other big challenge for me, at least when I was training, is that I had wonderful mentors in psychiatry who knew psychiatry really well. And I had wonderful mentors in palliative care who knew palliative care really well. And I didn't have any great mentors who could help me with how to integrate those skill sets. And it was such a rich thing to be putting together in my mind. The overlap is so beautiful, which kind of gets to the pros, which for me so deeply offset the challenges. It's really lovely to be a hidden psychiatrist inside of palliative care. There are so many beautiful things that the psychiatry skill set and lens and way of thinking through a person and a psyche, so many beautiful things come when you bring that into just the regular bread and butter palliative care sphere. And I'll add a few of these people on this panel I hang out with like very regularly over Zoom. It's been really fun as this field grows, the psychiatry palliative care field grows, and people like you get interested in it. It's so fun to be a part of this bubble and to be able to think through cases and think through the lens of psychiatry and reflect on palliative care. And there are a lot more pros, but I'm not going to go through them all because I want to give the other panelists some chance to say them. So going back, I would do it the same. And if I were to pick one piece of advice for you guys, I would say that people evolve and systems evolve and what you're going to want from your life evolves. So you'll find a way to make things work. Do your best to just really listen to what pulls you and let that be the compass as you make some of these choices. So with that, I'm going to pass it to you, Sam.
Hi, I'm Sam Weisblatt. As I said, I do entirely outpatient hospice, community hospice at this point. So my journey in med school, I was kind of torn between psychiatry and internal medicine, especially as a fourth year. I opted to start actually in internal medicine. And during that year, I was so fortunate to have, so it was a challenging year, as intern year is, I think, for most of us. And I was lucky enough that I had an elective, and I recall having a patient early on in that year that the palliative care team was involved with, and I hadn't had much exposure to that prior. So I thought I would give it a try. It was in January. I really needed the break right in the middle of the year. And it was just an overwhelmingly positive experience to be able to be with people and kind of see what palliative care has to offer. And it was really a respite in the back and forth, night and day, unrelenting pressure of the hospital, being an internal medicine resident. And here we are sitting with people and talking to them about who's around them and what they hang on their walls at home. And then, kind of using that as the framework to really try to build trust and build a relationship and talk about things that, by and large, most people have a really difficult time talking about when you're facing your own death. I decided to switch into psychiatry. That was really a better fit for me. So I moved and I did my residency at Cornell. I was fortunate enough to find a PGY2 spot, so I was able to just keep going. And it was really a profound experience to see. At that time, we were using the DSM-4, where major depressive disorder it's an exclusionary diagnosis for somebody that's having grief. So that is to say that experience of losing a close one in your life is so profound and it's so widespread that it actually is part of the normal experience. And certainly things have changed in DSM-5, but it was really eye-opening to see people that had gone through that experience and how profoundly affected they were psychologically. So between both experiences, it really kind of pushed me. I was able to arrange, I didn't have as much challenges as you did, Danny, but that's one thing I would recommend. I think in the several years since I've been out, I think those of us that are doing this work, there are more of us. There are more people that are in academia and other fields or other areas of the work. So I think you're going to hopefully have an easier time if this is something you choose to pursue. And just as Danny did, when people tell you no, you just have to keep going. If this is really what you want to do, you have to find a way to get that first experience kind of to confirm it so that you can go through it and see how you personally deal with being around death and dying and end-of-life illness day in and day out. You won't get a great sense if that's the career you want, by doing a 4-week elective, but you'll have some idea of emotionally how it affects you. And ultimately, I was interested in CL psychiatry, and then so I did that fellowship, and then hospice and palliative medicine at NYU in New York. And if you do decide to do the fellowship, you'll see there's mandatory time of exposure to hospice. I didn't know anything about home care. It was my very first experience, and again, that was just an eye-opening experience. I fell in love with it. Going in and out of people's homes, it's scary. You don't know what's behind the door, but you really get a sense of who people are and what's important to them and how they live their life. In general, I find that people live their lives, or they die, I should say, the way that they live their lives. And you can really see that from the time you walk in the home and you just look around in the living room, before they come out of the bedroom if they're able to walk. So during fellowship, it was clear that's what I wanted to do, and I've been doing that ever since. The challenges that I think that I faced similarly to what, Danny, what you mentioned, are a little bit internal, so kind of questioning, can I do the medical pieces of it? If you're a hospice physician, you're caring for most of the panel of patients that you have. I won't go into the details about why it's not 100%, but most of those patients are going to rely on you for palliative medicine care, end of life care, but also for basic primary care. And so I was able to rely a little bit on just the 1 year of internal medicine training, but also recognizing that the goals are very different. The targets are different. I'm not trying to manage a hemoglobin A1C and titrate to appropriate sugars. I'm trying to make sure the person doesn't bottom out and doesn't go into DKA, with the sugars over 600. That's really the goal. The same thing, with management of chronic illnesses, regardless of what it is. So you really kind of boil it down to symptoms, and you get a total wide-ranging exposure of that in your palliative year, hospice and palliative medicine year, if that's what you choose to do. But for me, it was a challenge. I'm fortunate enough. Looks like my video may have frozen, but can you hear me? Okay. Okay, thanks. So I was fortunate enough to join a very large hospice group. There's about 15 of us that do this full time, which is fairly unusual. I think it's very different outside of major metropolitan cities and also New York City in particular, that hospice is generally contract out, and it tends to be more part-time than full-time. But at least where I am, it's a full-time job, and I can rely on a number of other great people that are internal medicine background when I need help. And it probably wouldn't surprise you to learn that they come to me often. As was said before, and I'm sure you'll hear throughout this hour, there's an enormous overlap in the experiences that people have toward end of life. And in palliative medicine, you'll see that it's really not just a dyad of doctor-patient. It's really the unit of the patient and the people in the patient's immediate circle. And that's a unique challenge, but it has some great opportunities to really connect people and not only help the dying person, but also the people around them that are losing their loved one. So I will stop there.
Keri, do you want to pick up from there?
Yeah, I'd love to. Thanks, Danny. I'm looking in the chat right now. First of all, it's wonderful to see almost 30 people in attendance for the seminar, and just shows this growing interest in the subspecialty of thinking about psychiatrists going into the field, which I think all of us have noticed, this brewing, thriving interest, which is just very exciting. I'm also noticing in the chat that most everyone is a psychiatry resident or either a medical student going into psychiatry residency. So hopefully we can really tailor our talk to you and where you are in your training. So I'm Keri Brenner. Once again, I'm at Stanford University. I do all inpatient palliative care. And I'd love to tell you a bit about my journey that led me to this moment. I'm originally from Ohio in the Midwest. I'm still a Midwesterner at heart, although I've spent most of my time on the East Coast and West Coast professionally. I was a philosophy major in pre-med at the University of Notre Dame. And that kind of began my interest in thinking about existential issues, phenomenological questions, medical ethics, and really that enrichment of being a philosophy major at Notre Dame started helping me think about the whole person. And throughout undergrad and medical school, I was really fortunate to be able to go to Calcutta, India, and serve in Mother Teresa's Home for the Dying in Kalighat. And those moments of volunteering in her home for the dying expanded the spiritual dimension of how I wanted to be present to people who are suffering, and really aligned my heart toward knowing that I wanted to be present and with people who were at the end of their life. So I knew in undergrad and at the beginning of med school that I wanted to be with people with incurable illness ultimately. And so I did my medical school studies at Yale, and that was a great program because they have a lot of flexibility in their curriculum. And I was able to do a thesis on the phenomenology of suffering at that time to kind of integrate these phenomenological, existential, spiritual aspects academically into the way that I thought about delivering care to patients. I then went on to residency at MGH in McLean, and I matched in psychiatry residency, but to tell you how much of a struggle this was between internal medicine and psychiatry, I literally interviewed in both psychiatry and internal medicine And up until the day before ranking my list, I was undecided on what I was going to rank first in terms of psychiatry versus internal medicine. Ultimately, I ranked psychiatry first, and spent my time at MGH throughout residency, which was fantastic because I was able to do my intern year at MGH, which I think gave me a really robust, solid training in internal medicine, which was a nice foundation, knowing that ultimately I was hoping to be in palliative care or with patients with serious illness. A couple big decision points along the way for me. So the first one was that decision between internal medicine and psychiatry. And like other people have referenced, there was a lot of pressure at the time to do the tried and true traditional path of internal medicine. And even though I wanted to add on psychiatry, people would say, well, then you should double board. You should do both. You can't just do psychiatry. Now it's a whole new horizon for palliative care. We have so many people coming into our fellowship who are psychiatrists, neurologists, OBGYN, PM&R, family medicine. There's such a wide emergency medicine. There are all these subspecialties that are now transpiring within palliative care, which is just such an exciting time for the field. And I think that comes from the fact that now it is a very new field and a young field overall that's kind of growing out of its adolescence and starting to differentiate itself and getting more substantive with these subspecialties. And so I think that the field is more comfortable now with people coming in from other specialties, knowing that we need to have ambassadors to psychiatry, neurology, OBGYN, all these different spaces where palliative care needs to be present if we're going to really have roots and grow. The second decision point when I was at your stage in residency that was a really tough one was psycho-oncology versus palliative care. And I did a rotation at Memorial Sloan Kettering. I loved psycho-oncology. It was very interesting to me. Ultimately, for me, what drew me in the palliative care direction was that I noticed that I loved the medical aspects of serious illness. I really love the physical exam. I love being totally engrafted within medical teams where you could be the one helping lead the family meetings, working hand in hand with the oncologist, the cardiologist, really integrated within your own interdisciplinary team and then other people's teams as well, and doing that teaching in real time. I liked working with the intimacy of palliative care and working with the individuals, but then also working with families as well. And there was so much versatility to what palliative care had to offer. And I felt like I was kind of able to just go straight thrown into the deep of the heart of working with patients with serious illness in multiple domains. And I also loved the symptom management. I loved how, somebody's in a pain crisis or having horrific nausea and vomiting, and I actually had the tools to be able to get them better. And that's sort of a Trojan horse in to then eventually talking about the way that they emotionally process end of life care or the way that they're coping. And so I liked having that duality of my skills. A few other things. So my first job as an attending was at MGH. That was really exciting to see the way that being a psychiatrist on a team could be helpful. I was leading their interdisciplinary team rounds every week. I had a psychotherapy practice for palliative care patients and doing inpatient palliative care too. So that was really wonderful to see how even as a first year attending, you can become sort of an immediate expert in the field because you're bringing in this expertise of you knowing the psychopharmacology management, knowing how to handle delirium, knowing how to sit with people with incurable illness, which we learn how to do as psychiatrists. We learn that process is more important than outcomes, how to build a therapeutic alliance with challenging patients. All of those skills we get in our training and become instant experts in. So that's kind of, that's sort of my brief overview. There's a lot of other exciting things we can talk about, but I'll pass the baton to Dan so we have enough time.
Sure. I'll try to keep it brief too. There's so much to say about this. There we go. I'm having video glitches, but so my name's Dan and I work at Cornell where I do some inpatient palliative care, very little outpatient and a tiny bit of psychiatry, but predominantly research. But I'll tell you a little bit about how I got here because I think it really speaks to many of the themes that have already come up. So I, similarly to Keri, came to medical school really passionate about the idea of doing end-of-life care. I had studied HIV/AIDS narratives in college and how those narratives were used by politically disenfranchised groups to draw attention to the epidemic in the 80s. And a lot of those narratives were narratives on end of life, and in particular on people really living well at the end of life, people doing politically and socially meaningful work and advocacy in spite of and with very serious illness. And that was kind of profoundly moving to me, and inspired me to come to med school where I was hoping to do this kind of work. And I discovered psychiatry and had a kind of crisis in the way that I think has already been described, where I was like, well, I'm going to be a palliative care doctor. How can I do psychiatry, which is also something that shares so many of the same features that drew me to palliative care, and was told sort of, you can do it, it's not very common. And also up until the very last second was incredibly torn about whether to do medicine in palliative care or psychiatry in palliative care. And what actually ended up pushing me towards psychiatry was doing my palliative care rotation as a fourth-year student for a month and just realizing the immensity of the psychological suffering, the psychiatric comorbidity prevalence in folks living with serious illness, and how even in the incredible and profound work that was happening in palliative care, that suffering wasn't yet being fully addressed in a way that seemed like it was meeting the needs of patients and caregivers. And to me, that was very inspiring. It kind of gave me faith that even taking a route that was quote unquote alternative would work out in the end, because the need was there. And so I applied to psychiatry residency with a plan to pursue this path. Did some research and really stayed involved as a resident and did an elective, which I also really encourage folks to do. And I ended up deciding to do a CL rotation before, CL elective, a fellowship. A CL fellowship before I went on to do palliative care. And the reason for that was that I realized as a medical student and as a resident that the need for expertise in this domain was so great, that there was such a gap in folks who really had a deep understanding of the care of folks who have psychiatric needs and serious illness needs, that I needed to be as well trained and as expert as I could possibly be. And I thought that it would help me. Not that you can't do this without CL, obviously, but I thought it'd be helpful to me to sort of build that skill set. And I'm really glad I did, because I often joke that my palliative care fellowship, where I actually was a little anxious I wouldn't really be a psychiatrist anymore, was in a way my most intensive year of psychiatric training I think that I had, because all of a sudden I went from being in an environment where I was surrounded by really smart, experienced psychiatrists, and in my last year of training CL psychiatrists, to being like the expert, even as a fellow. So all of a sudden I was going in with my attendings into really complicated cases in clinic. I was being asked to see all these patients and weigh in. And it was like a very sobering and strange experience to be, on one hand, learning the medicine of palliative care, but on the other hand, sort of the de facto expert in psychiatry among folks with serious illness and at the end of life. And so that was challenging, but it was also incredibly enriching for me, and really let me come into my own, not just as a palliative care doctor, but as a psychiatrist. I knew I was going to love fellowship, but it was a big transition. And I have to say that the work of walking with people who are facing the end of their life, who are facing serious illness, whose world in a lot of ways is kind of dissolving, is just the most therapeutically rich, rewarding, profound, poignant, unbelievable work imaginable. I mean, it sounds like a cliche, but it felt like such a privilege as a psychiatrist to come into work every day and to be with people and bear witness, and at times, hopefully, relieve some of the suffering that people were carrying with them through this really profound moment in their life. And I guess I couldn't have known before I went in how gratifying that would be. And it really made me feel like I was being the very best psychiatrist and physician I could be. And sorry, I'm talking too much, I'll be quick, but I ended up transitioning to continuing being a clinician, but to doing research work and doing a postdoc, which I'm finishing now in research, because I realized that the needs were so immense. Even in my setting, I was getting asked to see so many patients, to weigh in on so many cases, to be involved in so many situations, that it clearly showed me that there's kind of a crisis in workforce, that there is so much need for expertise here that a single clinician is not going to sort of, or a small group of clinicians like we are not going to stop the gap in a sense. And so I became very motivated to try to think about ways to disseminate some of the expertise that folks like Keri and Sam and Danny have to a bigger swath of patients across settings. And that drew me to research, which has also been really rewarding, and which I would say has really leveraged and benefited the unique expertise that I built in my training in a way that's also been very gratifying. Happy to talk more about that, but I'll stop with that.
Dan, I feel like you're speaking to the joy of being like the undercover psychiatrist, you know, like all of your colleagues who would never have consulted psychiatry because you're there, like pull you in on cases that wouldn't have gotten the expertise otherwise. And the other way around, I had a patient in clinic who, it was a symptom management clinic, but you would think if you watched us in session, you would think it was a psychiatry clinic for her. And then finally the other day she said to me, my whole life people said I should find a psychiatrist, but there's no way I would ever connect to a psychiatrist the way I connect to you. And I was so torn, like, should I tell her I'm a psychiatrist? You know, like, will it stop my ability to give her this knowledge base if she knows? But anyhow, sorry, now I'm riffing. So why don't we open it up to, has anyone been monitoring?
Yeah, I've been reading through some of the questions, and one that Dan responded to that might be good for us to talk about is just around the particular fellowship programs that are open to psychiatry. Dan, you want to share what you learned,
Yeah, so I can say a couple of things about it. One from the research perspective, one from the experiential perspective. From the experiential perspective, when I applied to residency, like I said, I already knew I wanted to do palliative care. I was hyper aware of all of these fellowship websites that said, we either prefer or require folks to have completed training in internal medicine, family medicine. I already knew that I wasn't going to be eligible to do fellowship at Sinai, at MGH, and all of these places. By the time I was a PGY4 and I was applying, those were all gone, and I was invited and interviewed on all the programs. Not that I applied to that many places, but everywhere that I applied, and not just invited, but really warmly welcomed and celebrated for the skill set I was bringing in a way that felt very gratifying. And that's borne out in the data too. So I have a study that we're about to submit of training in psychiatry for palliative care fellows. And one of the questions that we asked was whether fellowship training directors would be open to accepting psychiatrists into their program. And 90-something% of fellowship program directors unequivocally said yes. And so the landscape is very different now than it was a few years ago. And my guess is that folks would really be welcomed and celebrated if they chose to take this path.
And I see how programs are actually thirsting for this kind of expertise and knowledge to be infused within their programs, because they see clinically the level of psychiatric comorbidities that we're called upon: anxiety at the end of life, panic attacks, depression, demoralization, delirium, insomnia, fatigue. All of these things are within the wheelhouse: how to run a family meeting well, how to communicate with difficult patients, addiction. All of those things we have such a robust training in as psychiatrists. And I think as the field now has become more developed, it's also become, as palliative care has become more developed, it's become more aware of the dire need to have depth of expertise in those domains.
Yeah. Even in ourselves, like I feel like when like certain skills I took for granted in residency, that like literally the ability to sit with distress doesn't come naturally. And I didn't realize how much residency in psychiatry had given me that skill until I found myself in a new setting. But what other questions?
Here's another question from Francis. To what extent are there palliative psychiatry fellowships versus palliative medicine fellowships?
That's a good question. I might not be the best knowledgeable on this. I know that there was one that I used to know of, right? That was at San Diego Hospice. It was specifically palliative psychiatry. And my understanding is that those are not like board certified type situations. It's just a more in-depth training, and that one doesn't exist anymore. But Dan, Keri, Sam, do you know of any other?
The only thing that I could speak to is when I was applying for fellowship, one of the places I applied, Sinai in New York City, there was a psychiatrist, I think that was the very first that they had at the time, and they actually changed the rotation schedule for that psychiatrist because they were under the impression, as I think many non-psychiatrists are, that psychiatrists can't do this or need their hands held, or whatever the preconceived notions are. And interesting, so when I decided to go somewhere else, and a couple of years later, that very same program director would ask my former program director, "Hey, how's your psychiatrist doing?" I just, sort of that's who I had become, and it was somewhat memorable to the people only because they rarely see a psychiatrist. I don't know if that program has changed their curriculum or the rotation schedule for psychiatrists, but certainly it's not specific palliative
you're
psychiatry.
Considering it, I would also say that like the versatility that comes with being board certified is pretty big. Like I feel like there are like 50 different careers I could do right now, like full psychiatry informed by palliative care informed by psychiatry, inpatient, outpatient, hybrid.
Yeah, maybe we could talk a little bit more deeply about that piece, Danny, because I think that's a great observation.
Yeah, which I don't think you would get if you picked a program that wouldn't board certify you. And I also want to say that Carly Zapata just joined us, the fellowship director at UCSF. Carly, we're excited to have you here. We're in the midst of Q&A, but Carly, I'm going to pose one to you that we just went over, but a question sort of came up about what programs are open to psychiatrists. Are programs like wary of psychiatrists, excited about psychiatrists? So like, how do you feel when a psych applicant lands on your lap? Oh, you're muted though. Yeah.
I will say that it's very program specific. And so some programs only accept applicants who have done family medicine or internal medicine. And then there are some programs like us where we accept applicants from literally any specialty. We've had people who are OBGYN trained and radiation oncology trained. Like we're kind of open to everybody. And that is really different from program to program. But I think in our experience, we want people who have all kinds of diversity in their training. And so our tendency is toward the excited part, probably for the reasons that you all have talked about. We have plenty of people who have done medicine and internal medicine. And I think the mental health part of palliative care that we provide is under-provided, as Danny knows. In our, certainly in our practice, we don't have enough psycho-oncologists. We generally don't have enough mental health support. And so we've used somebody who's trained as both in both as being a real asset and has complementary skills to the people who have trained in the more common fields. I don't want to say traditional, of family medicine and internal medicine. And so I would say for us, we're excited to have psychiatry residents apply. We actually just matched a psychiatry resident for our incoming class of 2020. What year is it? 2023, 2024, starting in July. not quite oriented in this new year just yet.
Awesome. And sorry to take us back, but then Keri, let me go back to you because I think you were going to riff on the versatility. But
yeah, and that was a question that came up in the chat too, like what job opportunities are available when you have this combination of hospice and palliative medicine and psychiatry. So maybe we can all expound on that. I can start. So in my own 5 years thus far of being an attending, I've been able to have a psychotherapy practice that I chose specifically for palliative care patients only, but I could have just done general psychotherapy. I've done inpatient palliative care. I've led interdisciplinary team rounds. I've done a lot of academic work on the psychological aspects of palliative care. I've also had many, people approach me asking, "Oh, would you be interested in doing addiction, psychiatry within palliative care because of the opiate epidemic, and doing more work in that space?" A lot of, people asking about, "Oh, could you think about building out this communication workshop training because you're a psychiatrist in this space?" Danny, Sam, do you guys want to speak a little bit more?
Sure. Certainly the realm of hospice is open. I certainly spoke about my experience, but it was kind of astounding to me to see all of the colleagues and the people that I had met at national conferences. People were staying in palliative medicine, and I don't know what it was about hospice. All of us, if you're trained in hospice and palliative medicine, you've experienced hospice, and so perhaps that leads people to want to stay away from it. But I'm happy to talk more about it if there are any questions. I think it's a fantastic job opportunity. There are a number of reasons why I think it's a great space within hospice and palliative medicine. But certainly those jobs are open to you if you do the hospice and palliative medicine. And I would say working, I think my agency is one of the top 10 largest in the country, certainly the largest in New York. We have 14 or 15 full-time hospice docs, and only half, maybe half, are hospice and palliative medicine trained. So you really can find a way into this field, even if you haven't done the hospice and palliative medicine year. I think it puts you at a significant disadvantage. And I highly, highly recommend the year of training, especially coming as a psychiatrist. You might experience more of the pushback that we've experienced about psychiatrists doing the work, but hospice is certainly open to you.
I think also, like, there's the bucket of being a psychiatrist in palliative care, and there's the bucket of being a palliative care doctor in psychiatry.
Mm-hmm.
You could really go both ways. I think all the four of us here tonight, and maybe we should have gotten a different person on the panel, but we all sort of have chosen to be psychiatrists in palliative care. And I do a little bit of both. Like next weekend, I am attending on the inpatient psych unit. It's going to be my bread and butter, manic admissions and things like that. But for me, it's actually nice to juxtapose them because I know where I'm personally happiest, right? But the flip side of that is there's this other huge need, like severe mental illness. Those patients do not get access to palliative care the way that most of it, like that other patients get access to palliative care. Palliative care is sort of built upon knowing a patient's values and helping their care be based in those values, right? And that's a lot easier with a subset of people who can communicate their values, who have the capacity to make choices that deviate from the do everything choice. That's very, very hard for our severely mentally ill population. So gosh, I can't wait to make friends at some point with somebody who wants to fill that huge need of the job pool too. But really, it's such an extensive amount of ways you could practice this. It's insane.
Apologies if you all already talked about this, but I was just going to add that I think if you're not sure, as a field of hospice and palliative medicine, we are really open to people doing this fellowship at any point in their career. Certainly we have people who come straight out of training, but I would say compared to cardiology or GI or some other fellowships, we have plenty of people who apply at mid-career because it takes them a little while to figure out that that's what they want to do, or they were, kind of getting some experience under their belt before they did fellowship. But it's perfectly okay to take some time to think about it and get some experience. We really only view that as a positive if you have experience in practice before you apply and are really kind of sure about what you are hoping to get out of fellowship and what you want to do afterwards. And so there's certainly no pressure to have everything figured out when you're applying to residency or when you're finishing residency.
And Dan, maybe you can speak to this, but I also have been approached at times about straight consult liaison roles. Even though I didn't do a CL fellowship, there was something I was enough in medicine because of the palliative care fellowship that people were interested, but
there was a CL attending at Columbia when I was a fellow who was a palliative care physician as well, and was the reverse of what many of us are doing. It was in a predominantly psychiatric role, bringing in that skill set, training our CL fellows and our psychiatry residents in some core palliative care skills, and sort of introducing many of the members of our division department to that field. And I think that's something that's really wonderful about the palliative care psychiatry combination in general, but really palliative care overall. There are so many clinicians that have done palliative care training and either built careers situated within palliative care, or have done palliative care training and gone back to work even in medicine as hospitalists or as oncologists, and brought that skill set there to train their colleagues in primary palliative care skills. And that is extremely, extremely viable in psychiatry, because psychiatry on its own is already so flexible, and there's not to be overly concrete, but there's a great job market, and that's true in palliative care too. So I really do think if you do this combination, the only limiting factor is what you can imagine and what you find brings you joy, because anything will be open to you anywhere between those two fields.
All right, we're getting a lot of other questions in the chat. So should
I was going to say, Amira, you're speaking. I think Amira asked this question, but you're speaking my language. She asked about training experiences if your program doesn't have specific rotations in palliative care, and I made a soapbox for just a second and say, I'm sorry, Amira, because the field is failing you. And if there was one thing I could change about psychiatry as a field, it would be like our need to recognize that this is actually one of our subspecialties. And just like everything else that we give everybody a sampling in and everybody experiencing, we're dropping the ball on this one. So having said that, I think be the first person at your program, because once one person does it, it's a lot easier for the other people to do it. And I think in fairness to our training directors, they didn't personally get the experience and they don't feel comfortable in that world. And so it's just not as intuitive. For me personally, I had to build it. I had to make an argument with the program director. And then finally, when he said, I understand it, you can do it in fourth year. And I said, no, I want to apply to a fellowship. They don't work on the same timeline. I have to do it before fourth year. And I ended up then having to reach out to palliative care and finding how they got elected people from other rotations. And it took a lot of work, and I'm not going to pretend it didn't. I hope anyone from UCSF listening has had an easier time since then. But anybody else have thoughts for Amira on how do you create this experience?
Yeah, and how and is having a solid amount of a palliative care experience necessary to apply for fellowship? That's kind of the part two of the question. I would say,
go on.
What I think in my experience, obviously, if you can do rotations and bake those in, like Danny said, that's really a foundational thing that could be very helpful. I think part two of that, if for whatever reason you get a lot of resistance from your program director, at least building the relationships with palliative care. So I think for me, those relationships were really critical of being able to reach out to different attendings within palliative care, doing a research project with them, writing a paper with them, having them as my mentors while I was going through my residency program. So they knew me, they knew my values, they could see, a little bit of my work. And so then when it came time to apply for fellowship, I wasn't a foreigner to them.
And Dan did a cool initiative, right, where he started doing joint rounds between psychiatry and palliative care, trying to find a way to merge the trainees and the training and the communities.
And making sure that your psychiatry projects are, we had at MGH, a senior year talk or, different talks that I had to give throughout residency. I was always sort of doing them about death and dying, incurable illness, palliative care issues. So then, when you're applying, when a fellowship director, and Carly might be able to speak to this, looks at your actual resume and CV, they can see that your interest is actually deep.
I'm going to jump. Oh, sorry.
Go ahead.
I'm going to jump in for a sec because I'm seeing a lot of folks are asking questions about, if you're a resident, how do I, Amira's question, but also medical students asking what kind of program should I match at? How can I position myself best to pursue this career path? And I would say, palliative care it's not cardiology, it's not GI. And I mean that in the best way. This is not a field where people are going to be judging you based on, your board scores and did you publish 1 million articles with big name people? We're looking for people that are passionate about improving the lives of people who are living with serious illness. And we know that people are coming from different geographic areas, from different types of institutions, from different programs. And we celebrate that. It's not like every program is just looking for people from big name academic centers who are on a research trajectory. And so when you're looking at programs, my advice would be go where you're going to be happy and thrive. And I know it sounds like a cliche, but not just in terms of palliative care. If you have an interest in addiction, go to a program that's going to meet that interest, because it's going to make you a better palliative care clinician and a more attractive candidate down the line. If you have an interest in community-based work, pursue that. If you're happiest and do best when you're near family or in a certain geographic area, that's going to make you a better palliative care fellow. It's going to make you a better palliative care physician. So those are the kinds of things that we care about in palliative care. So I wouldn't worry too much about, I need to go to this kind of big name program or I need to do this or that. Do what fuels you and find a way to connect it to your passion for palliative care, and that's going to resonate.
One thing that potentially could be helpful, if you can't find specific electives to do, if you're really struggling to carve that out for yourself, I might connect to oncology programs and ask them who they refer to when they have to refer for outpatient psychiatry, and then try to directly connect to those psychiatrists. Most psychiatrists out there, right, are not hospice and palliative medicine trained, and death is all around us. So even general psychiatrists are dealing with death as part of their practice on a day in and day out basis. And spending time with those and learning from those folks is another area where you can get a sense of what is it like to do psychotherapy with someone who's dying or whose child just died, et cetera.
And we have, I feel like I want to invite like everyone here to join the AHPM SIG,
Yeah.
Academy of Hospice and Palliative Medicine. There's like a special interest group for psychosocial and mental health, and I'm running it this year, but we meet regularly. And so like, feel free to come and like find mentors there, hear the types of stuff we're talking about, the stuff we're interested in, like join into our projects. Feel free to email me if you want more information. And Carly, you also may be able to weigh in on this whole, like, if I didn't get to have a lot of experience in palliative care, will that be a hindrance? If I didn't make a mentor in palliative care who can write me one of my letters, will that be a hindrance? If I go to a community program instead of a academic one, will that be a hindrance? I see a few questions in this vein.
Yeah, those are all great questions. And I was actually going to echo Danielle's sentiment about go where you will be happy, because if we care about nothing else in palliative care, it's like, we know that time is short and we want you to have spent your time well and spend those 4 years where you're going to be happy kind of regardless of your long-term career plans. And I think to Danielle's point also, it really comes across in people's applications when they have done something that they feel committed to and are passionate about. And so there's no need to kind of go about it in a box checky way, like do what meets your other life goals. And I think, Danny, to your question, we certainly recognize that not everybody has the same access to palliative care experiences before they're applying to fellowship. And really what we're looking to see is that you know enough about what the field looks like to be sure that it's worth your investment to do the training, our investment to train you. And that can even be something, it doesn't have to be a formal palliative care elective. I was thinking, I think, Samuel, you had suggested asking oncology where they were referred for psychiatry. And I was actually going to say the same thing about hospice, that there is lots of space to do hospice volunteer work. And that is like certainly valuable. And having a letter from a hospice medical director certainly counts as, if not a palliative care mentor, counts as someone from the field who is vouching for your interpersonal skills, for the way that you work on an interdisciplinary team, which is really something that we look for in people's applications, is that you've had that experience working on an interdisciplinary team and you value the role of everyone in hospice. Is a great place to test that out. And then if you aren't able to access an elective, I would actually recommend having one of your other letter writers see that somewhere, so that we know that it wasn't just that you didn't get around to it or you didn't feel like it, that so we can really take in that difference in access for you compared to someone else into the equation, and consider how much experience you've been able to get with the resources that you had. And that's perfectly okay, but be as transparent as you can about if you don't have a lot of palliative care experiences, the reasons behind that and the efforts that you made to overcome that, if that makes sense.
There's a question in the chat about kind of what subspecialty conferences, what in groups do we belong to? Does anyone want to speak to that? Organizations?
Sure. So I would, do you want to go, Danny? Sorry.
You go.
Oh, I was just going to say, the American Academy of Hospice and Palliative Medicine is sort of our APA, and it's a really wonderful organization. It's very welcoming. It has a lot of resources for trainees and early career folks across different domains: research, clinical, training, anything you can imagine, job searching. And I really I recommend checking that out. ACLP, the Academy of Consultation Liaison Psychiatry, is also really wonderful and has a number of palliative care trained psychiatrists that are in the CL world as well. And finally, if anyone is interested, we'll share our contact information at the end. I have a small listserv of psychiatrists that trained in palliative care and trainees who are interested in pursuing that path. That is a much smaller resource of a very select, not because we're exclusive, but just there aren't that many of us. So it's a smaller cohort of people that may be able to serve in a mentorship role or answer questions for you, and that's open to any folks that are interested. So we'll give information about that as well.
And I'll put those into the chat, those two groups Dan mentioned.
There's also a certification board within hospice, because most of the hospice physicians around the country are not boarded in hospice and palliative medicine. So I think it's relatively recent, but it's an opportunity to really hone that skill set above and beyond the medical pieces of hospice and palliative medicine. There's an enormous burden of administrative knowledge that you need, fortunately and unfortunately, to be a hospice physician. So that's a separate subgroup within hospice and palliative medicine.
If you were to pick just one, I would pick AHPM
Mhm.
and Dan's listserv.
Agreed.
Dan's listserv. Because these things you'll realize when you're not a trainee, they start to get really expensive. So you get more selective on memberships you want. Keri, I feel like this question in the Q&A, it speaks Keri Brenner to me. How is a psychotherapy session with palliative care patient like? Specifically, are there certain modalities that you find helpful? Also, how to address the time-limited nature of the psychotherapy?
I think this builds on what Dan was describing earlier. There is something so profound about being able and privileged, truly privileged, to be able to access patients when they're facing their mortality and transience. It's almost like this, it truly is like a backstage pass into people's lives and what's most important to them. And in some ways, the life-limiting nature of the illness catalyzes the psychotherapeutic process. So what might normally take this long runway to sort of have unconscious processes come to the surface, when patients are aware that time is short and they can feel that viscerally and experience that as the life, as Dan described, is sort of dissolving around them, you find that many of those processes get accelerated and come to the foreground really quickly. I even see that in my inpatient practice, and just a visit or a micro moment with a patient, all of a sudden something very salient gets mentioned about an interpsychic or interpersonal dimension that needs to get worked out and worked through in order to have a sense of resolution and peace at the end of life, because people are looking for that, and they're thirsting for that kind of consolation and peace. And so it's a privilege to be able to be in that sacred space. Formally as a psychotherapist, when I did it in that work, but then also informally, as we've all described, being sort of hidden psychiatrists within the field. And I think our colleagues who are internal medicine trained feel the same way, and they're thirsting for the skill sets of, what do I do with this? All of a sudden the patient's bringing up this, really rich information that's so psychodynamically important. And I don't know what to say or do next. And that's where our expertise can be really helpful. Yes, there are these formal things like Gary Rodin's calm therapy, Harvey Chachanoff's dignity therapy, Bill Breitbart's meaning-centered psychotherapy. Those are all awesome interventions that I think inform our field on how we face end-of-life work. I think different people are magnetized to different ones. And yet there's a space for just truly just having some like psychodynamic knowledge, and how do you infuse that within mainstream palliative care too, and not necessarily doing a formal intervention.
And I would say, like, in outpatient palliative care, even though it's not psychotherapy, I don't think I make it through a clinic without using psychotherapy skills. Like, people are having to tolerate uncertainty, like anxious people who are controlling in their world are coming to me and the rug's been pulled out, right? And I can sit with them and we can do some ACT, and we can talk about, like, how do we tolerate that? We can talk about dialectics, we can do some DBT.
Yes.
Like, there's so many,
like simple CBT method just in one session.
Yeah, totally. CBT, we can talk about, like mantras, or okay, when, like, there's just so much stuff. It's so rich. Like, I feel like I'm doing psychotherapy so much. And I laugh sometimes with our psycho-onc people, because they're like, wait, we're passing back and forth this patient, and we're both sort of doing the same thing. But
there's so much opportunity with that. Oh, sorry, Dan.
yeah, no, you go.
Oh, I was going to say that also creates so many opportunities for really rewarding teaching and scholarship. So just like looking at this other three folks I'm with, Keri and I wrote a series of papers on basically psychotherapeutic aspects of palliative care, along with some of our colleagues, which was so fun and such an interesting experience. Danny, Keri, and I are involved in a number of initiatives and projects right now teaching some of these psychotherapeutic skills in the palliative care world. Sam was involved in the paper series and helped to write the sort of hospice end of life psychological aspects paper. So there is a huge amount of room to do educational, scholarly, and research work around these topics because it's such a new and exciting area in the field. And to me, that's very fun and resonant. It creates a lot of room for fellowship between like-minded colleagues and for variety in my day-to-day work. So.
Any other burning
Just
questions?
as I would just to piggyback on what you're saying, Dan, because we're such a small subset of psychiatrists, the amount of literature that exists in this domain is minute. And I'm very impressed. I was fortunate enough to work with Dan as a resident when Dan was a student, and I could just see his passion for learning and his passion for scholarly work, and he's really taken on this enormous challenge, and others, fortunately. But if they're looking, when they're looking, folks are looking to do research in this field, and they're looking for papers that exist. I can't imagine how much mining you have to do just to find a few of them. So it's really an exciting time to have people joining both clinically and academically.
Yeah, unlike cardiology, like, I think about cardiology, such a tried and true field where you need to have like this huge grant and do decades of studies just to get your name out there. In palliative care, I mean, you could pick a couple different topics and papers and suddenly you're the expert in that domain. And it's because it's such a new, young field that it has a ton of breadth. I mean, it's expanding enormously throughout the country, but now it's at a phase where the field needs depth. And so to bring this kind of expertise to the field offers an immediate footprint and contribution.
And I don't want any of you out there, if you don't have one of us at your institution, I don't want any of you out there to, when you're going through this path, to feel like you don't have someone to help integrate this, right? So like reach out to us. Yeah. Like we're not just in our institutions, we're all in this together, and we're so excited you guys are interested in this field. And if there's enough of us, like maybe we'll meet regularly, and wouldn't that be fun? And we can, process the experiences as you go. And so reach out to us.
Danny, a final question that came up here was somebody had mentioned the use of featured films to train clinicians to be of help with patients, something like, Tuesdays with Maury, Shadowlands, Wit, Departures. Any other films or even like lay books that come to mind?
Our UCSF palliative care team has a film on Netflix that's called Endgame that follows the team through taking care of a patient. I have no idea what year that happened. It was sometime before COVID, and all of that time is kind of a blur, but that one comes to mind.
I think that Irvin Yalom's work, it's, these are book publications, but Staring at the Sun is a really good starter. An entry point into thinking about the existential aspects in a narrative form, and pretty accessible.
Francis, I love that you asked this question, because if you hadn't been here, I probably would have recommended people reach out to Francis Liu. You do this to think through this one more. I feel like you are in many ways an expert.
Really quickly, we have a couple of minutes. I'm just seeing Layla asked about the difference between psych oncology and palliative care, which we talked a little about, but I'm happy for us to weigh in a bit. I can say, having done a CL fellowship, that there's a lot of overlap, and part of it is also what you do as a clinician, but probably psych oncology, the frame is going to be really psychiatric, and it's that, you may attend to physical symptoms as part of that, but you're really going to be seeing someone in the context of the psychiatric frame that and love. In palliative care, it's a different frame. You're touching patients, you're attending to their physical needs, often first and foremost, because if someone is in extreme physical distress, you're not going to be able to do a lot of the other work that you need to do. You're going to be thinking a lot about the medical. So in a similar way to CL, but maybe even more so. And I would say also palliative care is more I don't want to say more interdisciplinary because that sounds pejorative towards psycho-oncology. I think for most psycho-oncology roles, you're a little bit more isolated in the work you do, which can be a good thing for some people. It's a little bit more of a one-person endeavor. You know, the psychiatric frame is very much like patient and clinician, and you may be interfacing with the oncologist you're liaising with, but you're basically one-on-one with the patient. The palliative care frame is really different. Most palliative care work is really a team sport. You're working super closely with other prescribing clinicians like nurses and physicians, with chaplains, with social workers. And so there's a lot more emphasis on the team aspect of it, which I really love, but I'm sure for some people, they like sort of being in control and having that smaller frame. I don't know what everyone else thinks.
Those are really great points. Sorry. The other thing to think about is how you like working. So similarly to what Dan's talking about, but if you're practicing as a psychiatrist embedded within a cancer clinic or a cardiology clinic, at times you can be looked at as sort of you're held on a string. You're the puppet on the string, and you're expected to move when other people are pulling at you. Unfortunately, that's not so uncommon. Whereas if you're practicing, if you're in a standalone psychiatric clinic, or if you're in a standalone psychiatric practice, then you have the one-on-one work with the patient, but you also have your department. You have people that are there backing you up and working with you, and it's more the work that you're doing. The clinical work is certainly taking a forefront, and no one is trying to pull you in one direction or another, or I come into your office, I need you to see my patient right now. So I think those are practical things that I wasn't so aware of throughout all of my training that really come to the forefront when you start looking at attending work, and you want to be sure that you're talking to attendings at places where you're looking at openings to get a sense of what it's like, because going through the interview process, it's sometimes hard to pick out the nitty-gritty of that.
I would also add, like, not our patients, not gonna be true for all of our patients, but the vast majority of patients that we see in palliative care are suffering, right? And suffering is such an interdisciplinary concept, but they're suffering on probably multiple domains. And the subset of those patients and the subset of that suffering that will make it to you as a psycho-oncologist is a lot smaller. Not a good thing, not a bad thing, just a difference, right? It's going to be people who need, like, who have a mental illness, who need some kind of psychopharm, who are willing to see a psychiatrist, who, you know, like, it's a smaller subset. And it's, for me at least, been a real pleasure to be able to, like, hold, palliate, and tend to the suffering of a larger subset of patients. But.
And along those lines too, you're going to get to meet people in the sphere of palliative medicine who, if they knew you were a psychiatrist, they would walk out the door, right? They're intently not going to talk, at least initially, about what's going on between the ears, right? They want to talk about everything else, but you know, their headspace. But it gives you an opportunity really to, as was said before, to meet people where they are. Maybe you'll get the opportunity to talk about those things, or maybe you won't, but it's an opportunity really to help people in that critical need in their life.
Awesome. Well, we're 3 minutes past, so thank you guys for staying a little over. Thank you for everybody who came. We really thank you, Carly, for joining us. We really hope that this was helpful and was meaningful, and it's the start of the discussion. Feel free to reach out to us. We are, like, beyond excited that you guys are interested in joining us in some form or another.
Maybe we can quickly put our emails in the chats. I just threw mine in, but if anybody wants to reach out or ever wants mentorship or to talk about our careers, I'm sure we'd be happy to help out in whatever way we can. The future is bright. It's such a pleasure to get to see so many folks who are excited and passionate about this stuff. So this is really wonderful.
Exactly.
It's so great to hear, you know, from several years ago, well, this is what it was like when I was applying, right? And now things sound like they're really changing for the better.
Yeah.
More work to do, but certainly we're going in the right direction.
Lots of UCS love going on here too in the chat. I would say lots of Pally Psych love too.
Mm-hmm.
I love it.
Thanks for organizing us, Danny.
Yes, thank you, Danny.
Thank you.
And thank you
so
everyone
much
for joining. I mean, truly, this is a community that we all belong to across the country. So thank you for being a part of the community.